Hello friends, welcome back to the lectures on nephrology. Before we start, I would like to thank you for subscribing our channel, allornonelaw. So let's talk about an important topic, that is chronic kidney disease. This topic is often, I would say, when I was studying for my boards, I felt it to be a little bit boring topic. However, this topic is the one which you cannot afford to miss when it comes to boards. So let's just talk a little bit basics about chronic kidney disease. The objectives for today's study includes as follows. First, we'll try to define what chronic kidney disease means. Then we'll go into what are the different stages of the chronic kidney disease. Then comes your, as we talked earlier, is definition, and there is a classification of the chronic kidney disease, which essentially talks about the causes for the chronic kidney disease. Then what are the manifestations of this chronic kidney disease, and then we'll talk about the treatment options, the major part of which is renal replacement therapy. Now, as the name itself tells, it's a chronic disease. In order to diagnose somebody with a chronic kidney disease, you need a structural or functional abnormality of the kidneys which lasts for more than or equal to 3 months. How do you demonstrate this? Is by calculating somebody's glomerular filtration rate, that is GFR. And the way you calculate the glomerular filtration rate is by calculating the creatinine in the blood. You have different formulas. The two of one are very commonly used. One is MDRD, that is modified diet in renal disease. It's a very commonly used formula to calculate the creatinine clearance, which is nothing but the GFR. Or you can use the Cockcroft-Gault equation. Now, when they did the studies, the MDRD equation was more accurate than the Cockcroft-Gault equation, but the limitation to the MDRD formula is you can use it for the patients up to the age of 75. Beyond that, this formula is not really applicable, and that's when you use the Cockcroft-Gault equation to calculate somebody's creatinine clearance. Also, for people who are morbidly obese or who are on the extremes of the BMI, you use Cockcroft-Gault equation rather than the MDRD. MDRD formula also has a little difference in terms of creatinine clearance calculation for Caucasians and African Americans. So if you are able to demonstrate that somebody has a glomerular filtration rate of, I will tell you the value as we talk about the stages of the kidney disease. If you are able to demonstrate that there is damage to the kidney which lasts for more than 3 months without a recovery, that's when you call them as a chronic kidney disease. This, I would not be too keen on this slide, but I would just make it clear. Some people might be getting confused at the end of our lecture as to what does an end-stage renal disease means and what does a kidney failure or pretty end of the renal failure means. Whenever you use the term as end-stage renal disease, you mean to say that the patient is on a renal replacement therapy, which is either the dialysis or the transplantation. When somebody has a creatinine clearance of less than 15, these are the people who would, under normal circumstances, qualify for renal replacement therapy. But if they refuse it, those are the patients you call them as in end stage, in renal failure. So we defined what is chronic kidney disease. Now let's talk about the classification of the chronic kidney disease. The two most common diseases to cause the chronic kidney disease And two most common diseases that lead the patients to go onto the end stage renal disease is right up front. The most common being the diabetic kidney disease or the diabetic nephropathy, the second being hypertension. The remaining causes are common but not as common as diabetic and hypertension. Among glomerular diseases, you have all bunch of glomerulonephritis causing nephritic/nephrotic syndromes. Certain drugs and certain malignancies can present with glomerular diseases progressing to chronic kidney disease. You remember vascular diseases affecting the renal arteries like renal artery stenosis, either unilateral, bilateral, be it in a young person caused by fibrovascular dysplasias, or more common in elderly or people over the age of 60 is atherosclerotic disease causing narrowing of the renal arteries. Obviously, hypertension causing long-standing nephrosclerosis because of the medial intimal hypertrophy. Then tubulointerstitial diseases, which basically involves interstitium and the tubules of the nephrons. Repeated urinary tract infections usually tend to cause something called as a reflux nephropathy, which untreated would eventually lead to CKD. Cystic diseases, the common being the polycystic kidney disease, which you have two flavors in it. One is infantile, another one is adult type. Then in people with a transplant, you have this allograft nephropathy. The drug's toxicity itself, these are the medications that you use for immunosuppression like tacrolimus, cyclosporin, which can itself cause chronic renal failure, which over the period of time would lead to chronic kidney disease. Then transplant glomerulopathy and recurrent diseases as well. Now this slide essentially gives you an idea of the different stages of the chronic kidney disease. Now, the reason why one should know about this staging system is it's more important from a primary care standpoint is to identify what stage is the patient in for chronic kidney disease and when to refer it to nephrologist. Because remember, when we talk about the treatment for the chronic kidney disease, one of the big part of the treatment is prevention of the progression of the disease. And there are ways how you can prevent the progression of the disease, because your goal is to prevent the patient from getting onto end stage renal disease state is the main goal. Whatever damage has happened cannot be reversed back. So in a patient with a chronic kidney disease, you cannot expect their nephrons to start working miraculously. Instead, you would try to slow the progression of the disease. So on the left hand side, you see the stages from 1, 2, 3, 4, 5. So as you go from 1 to 5, the disease gets worse. So 5 is worse and 1 is the best. The normal GFR or the creatinine clearance being around 120 to 125 ml per minute. Now you might be wondering why stage 1 is a disease when you have a normal creatinine clearance. Well, if you ask me that question, then the essential component, if you remember when we were defining chronic kidney disease, we said either functional or structural abnormality of the kidney. When the GFR is more than 90, what it means is there is some structural problem in the kidneys, but there is a compensatory mechanisms happening in the rest of the nephrons because they undergo hypertrophy and they are trying to compensate for the GFR. So essentially that's what it means. So how do you demonstrate that structural abnormality? It's by doing the protein in the urine, and that's nothing but the proteinuria. What I would want you to remember at this stage is just look at the stage 1, which is normal GFR but some kidney damage, which can be demonstrated by proteinuria. As you go down, it gets worse, and remember what is called as renal failure or kidney failure is when the GFR is less than 15, and that's the time when you initiate dialysis. One thing to keep in mind is when we say dialysis, we are talking about this is dialysis in patients with for dialysis in patients with chronic kidney disease, that is a stable but slow worsening renal disease. I'm not talking about any acute indications for the dialysis. So when the GFR gets less than 15, you cannot wait to see the common complications from a kidney failure before you start dialysis. For these patients, you just start them on dialysis once they get into the GFR of less than 15. You start preparing somebody for dialysis when they are at stage 4. So that's the reason that one should be aware of the stages. You usually refer them to the nephrologist when they are close to stage 2 or stage 3. I would say usually stage 2, you should refer the patient to the nephrologist. So these are the 5 stages of the chronic kidney disease. Stage 1, 2, 3, 4, 5. 5 is what it should be in your mind, a GFR of less than 15, and that's the time when you initiate dialysis, or I would say a renal replacement therapy. Let's talk about some of the clinical abnormalities in chronic kidney disease patients. As you see, I basically have included all the systems in the body. It's not just cardiovascular, pulmonary, neuromuscular, or dermatologic or gastrointestinal, but it also includes fluids and electrolytes, endocrinopathies, and hematologic/immunologic. This in itself can speak to you that how important the kidneys are for having a homeostasis or a homeostatic mechanism in the body. I will just quickly describe to you some of the abnormalities that you tend to see in patients with chronic kidney disease, but I won't go in details of those because there are a lot of them. Just to name few of them that one should be aware of under fluids and electrolytes. Obviously when I say fluids, it's going to be a volume overloaded state because kidneys cannot excrete the fluid. So you tend to see pulmonary edema, recurrent pulmonary edema in these patients. You tend to see pedal edema, worsening leg swelling. Then endocrinopathies, which includes, among electrolyte disturbances, you tend to see hyperkalemia, hypernatremia, metabolic acidosis, and hyperphosphatemia. And hypocalcemia is also an important complications from the electrolyte standpoint. Endocrinopathies include, most commonly, is secondary hyperparathyroidism, vitamin D deficiency, and aerodynamic osteomalacia. Neuromuscular disturbances, the most common presenting complaint in patients with, especially with end-stage renal disease, is fatigue. Others include peripheral neuropathy, restless leg syndrome, paralysis, seizures, coma, muscle cramps. There is an interesting thing that happens in patients when you subject any advanced chronic kidney disease patients to dialysis, and that's called as dialysis disequilibrium syndrome. What happens is when these patients have a high BUN, is when BUN is on higher side and you dialyze them and suddenly you reduce the BUN in the blood, there is an osmotic shift that happens because BUN has some osmotic effect in the blood, and that can cause a sudden change in the fluid status of the brain cells, causing brain edema, cerebral edema, and causing worsening mental status. So that's called as dialysis disequilibrium syndrome. So you should suspect this disease when you subject somebody new to dialysis and suddenly reduce their BUN. Among cardiovascular causes, you can think of arterial hypertension, congestive heart failure. We talked about pulmonary edema because of the fluid overload. Pericarditis, uremic pericarditis is one of the common indications to initiate dialysis. Uremic lung is one of the manifestation from pulmonary aspect. In dermatology, you tend to see the calciphylaxis, which means the calcium and the phosphate combines, forming salts getting deposited into the skin. Patients usually have itching as a very common complaint, ecchymosis, and uremic frost. Among GI symptoms, anorexia, nausea, vomiting, peptic ulcer disease is something you tend to see as well. Among hematologic, the most common being anemia. Remember, there is an entity called as anemia of chronic disease. Again, it's a big topic of discussion. Leukopenia, hypocomplementemia is also some of the complications that you tend to see with chronic kidney disease. Now, if you look at this slide, I have mentioned about the common complications from chronic kidney disease patients that one should be aware of, because this is more so in terms of management aspect. hyperkalemia, hyperphosphatemia, hypocalcemia, hyperparathyroidism. Now hyperkalemia is obviously, the reason being is that kidneys cannot excrete. Kidneys are the one of the route for excretion of the potassium from the body. The other route being is bowels. So if kidneys are not functioning, obviously you tend to accumulate potassium, causing hyperkalemia. Same thing with phosphorus. When you are not able to excrete phosphorus from the kidneys, you tend to get hyperphosphatemia. Now this phosphorus which is up in the body combines with the calcium in the blood, forming calcium phosphate stones, crystals, which get deposited everywhere in the body, and that's called as calciphylaxis. And that's the reason why you tend to see hypocalcemia. When you have hyperphosphatemia combined with hypocalcemia, the PTH hormone is secreted, and that's why you tend to see hyperparathyroidism, and then because of which you tend to see more of a adynamic bone disease and brown tumors, which we call it as, that is osteitis fibrosa cystica. Then because of the calcifications in the blood vessels, you tend to see a premature coronary disease in these patients. Fatigue is a common complaint just because of the overall derangements in the electrolytes and anemia. Pericarditis is because of the uremic toxin accumulating in the pericardium. Same thing in the lungs, causing uremic lungs. Pruritus, we talked about, deposition of the calcium phosphate crystals. Peptic ulcer disease, just because of the uremic toxins causing increased gastric acid secretion. Anemia of the chronic kidney disease is mainly because of a reduced erythropoietin in the because erythropoietin is a hormone which is secreted by the kidneys. Now this slide essentially tries to just give you an idea as to manifestations of the chronic kidney disease, starting from stage 1 CKD to up to stage 4 CKD, is how they progress in terms of the incidence. If you look at hypertension, overall the physical activity, the serum calcium falling below, hemoglobin, albumin is a good marker of liver function and overall health status, I would say. Serum phosphorus, everything starts getting worse. That's the whole idea of putting in this slide, is to just show you from GFR, from stage 1 CKD onwards to stage 4, how the things get worse. So one should keep in mind these things, and that's the reason why we would usually refer these patients to a nephrologist, so as to have a close follow-up. This slide gives you an idea as to the cardiovascular mortality in patients, because that's one of the most common cause for death in patients with chronic kidney disease. And that's nothing but, if you look here, the annual incidence of cardiovascular disease increases as the the kidney disease progresses. And in patients with dialysis, you see, compared to the general population, the cardiovascular mortality rate is higher, and that's reason is pretty simple, and that's because of increased calcifications and premature coronary artery disease, causing all these things. Now, talking about the treatment modalities for patients with chronic kidney disease, what one should be focusing on is, remember, you cannot reverse the damage that has already happened. So the goal at this point of time is to treat the complications that can arise, which we all talked about, like fluid and electrolyte disturbances, endocrinopathies, and whatnot. But the most important goal for patients who have a stage 1 to 4 is to delay the progression of the disease. How can you delay the progression of the disease? We will talk about it. Stage 5 CKD, the simple treatment is renal replacement therapy. Remember, stage 1 to 4, treat the complications and delay the progression of the disease. Stage 5, time for renal replacement therapy. There is no need to wait. Patient might be feeling fine, patient might be walking, clinically doing pretty good, but stage 5 CKD, boom, you need to start on the renal replacement therapy, because they can go into complication at any given point. You don't know, they can end up with a complication and have a worse mortality. Now remember, when I told you about delaying the progression of the disease, what one should be aware of is proteinuria in chronic kidney disease, because this is the one which is going to be causing damage in chronic kidney disease patients. Studies have shown, there were studies on patients with diabetes. The famous ones are UKPDS and DCCT or DCCT edit trials, which basically showed that a strict glycemic control would prevent the progression of a kidney disease by reducing the you know by reducing the amount of proteinuria. The proteins basically, which when they are filtered from the glomerulus into the tubules, when they are in excess, they tend to cause damage to the tubules, and that's why they cause, they become toxic. So what you do is, under ideal circumstances, you should know what is the total protein excretion over 24 hours of urine excretion. But imagine what, it's so cumbersome that you cannot do urine protein creatinine ratio on every single patient. So in such cases, we tend to calculate something called as albumin to creatinine ratio, and if it's more than 30, we call it as, less than 30 is normal, 30 to 300 is microalbuminuria, and anything after 300 is considered to be proteinuria. And you see the actual problems begin when the proteinuria is more than 500 to 1000 milligrams. That's when you typically say there is a heavy proteinuria happening. Nephrotic range proteinuria is more than 3 grams. An important concept in delaying the progression of the kidney disease is by reducing the amount of proteinuria. That's my whole point in bringing this idea. So if you look here again, coming back to the staging of the kidney disease from stage 1 to stage 5 on the left side, and this is basically the management aspect on the right side. So I would like you to focus on this thing. Is basically, this reinforces the first statement, saying that patients with stage 1 to 4 CKD, try to see if you can slow the progression rate, and the way you can do is by reducing the amount of proteinuria. And how can you reduce the proteinuria? So the most famous, the well studied medications to reduce the proteinuria are ACE inhibitors, or angiotensin converting enzyme inhibitors, or angiotensin receptor blockers. It doesn't matter, there is a concept that patients with diabetes and hypertension, the classic treatment for the boards was ACE inhibitors. However, now we know that even patients who does not have diabetes but have proteinuria, please use ACE inhibitors / angiotensin receptor blockers, which reduces the amount of proteinuria and tend to delay the progression of the disease. Now this is basically a slide to show you how the incidence of the prevalence of the end-stage renal disease in United States has gone up from 1984 to 2010. And guess what? The reason being, there are more number of hypertension and diabetic nephropathy patients that we are seeing nowadays. Here, this just gives you a quick idea as to patients from a normal GFR going to an increased risk to damage of the kidneys, to reduce GFR to kidney failure, and you basically starts from screening to the treatment, from prevention of the complications and reducing the progression of the disease, to starting them on renal replacement therapy. So how do you reduce the progression? How do you prevent the progression of the kidney disease? Is, remember, we talked there are two most common causes for the chronic kidney disease. One is diabetes and another is hypertension. So your goal is to have a good glycemic control, and the studies behind those are UKPDS and DCCT trials. These studies showed that good glycemic control can delay the progression of the kidney disease. So we have a good evidence behind that. And how do you do that? Is by using ACE inhibitors or angiotensin receptor blockers. The second goal is to control the blood pressure, and the way you achieve is by the first agent using is ACE or the ARBs, never used in combination. And the second one is, if you are not having a good control, then you need another agents like calcium channel blockers, beta blockers, diuretics, and basically you try to achieve a blood pressure of less than 130 to 80. There are a lot of controversies. I don't want to go into details, but for board purposes, you can remember a blood pressure of less than 130 to 80. The last one is the renal replacement therapy for stage 5 CKD, is to initiate the dialysis. How do you treat it? Is there are different modalities. One is a peritoneal dialysis, wherein you live the dialysis fluid into the peritoneal cavity, because the peritoneal membranes have a very good semi-permeable membrane for the exchange. There are different types in it. One is a continuous ambulatory peritoneal dialysis, means you basically leave the fluid in, and then every 2 hours you take it out, and then again infusate the fluid again back in into the peritoneal cavity for dialysis. There is another one which is nocturnal intermittent peritoneal dialysis. Again, a very similar concept to continuous, but it's only done during the night time. Hemodialysis is another one, which would basically, you draw the blood from the venous side, dialyze it, remove all the toxins, adjust the electrolytes in it, and take out the fluid from it, and then put it back into the arterial system. There is a one thing which you usually tend to see in patients with patients in the setting of intensive care unit, which is called as CVVHD, or continuous veno-venous hemodialysis. Means basically it's like a functioning kidney outside the body, you can call. Here you're not trying to when you do the regular hemodialysis, you usually take off like 500 ml of blood outside the body. So if somebody is hypotensive in patients with septic shock, you cannot really do hemodialysis because they don't have enough room on blood pressure. Such patients, you subject them to continuous veno-venous hemodialysis, and that's what helps them is to maintain their blood pressure, and still you are able to dialyze them. Then renal transplant is the ultimate treatment for chronic kidney disease patients. So patients who get onto hemodialysis, they are on transplant list, and whenever they get the eligible donor and they are on the top of the list, that's when they get the renal transplant. Once you get the renal transplant, you do not need hemodialysis unless you fail the donated kidney. Alright, folks, this is the end of the chronic kidney disease topic. Hope you learned and enjoyed the teaching. Thank you.